Can you hear me?
Yes, yes.
Yes, we can hear
please,
you.
Okay, good morning, everybody. Can you hear my screen now?
Yes, it's good.
Can you see it?
Good.
Okay.
Yes.
Thank you. Thank you very much. First of all, I want to say thank you to all of you and congratulations once again for this beautiful meeting and this beautiful opportunity to be here to talk about anatomy, because anatomy is the backbone of surgery, especially neurosurgery. And I wanted to say thank you to Dr. Hamed, Dr. Majed, and my brother Haib Sherian here. It's my honor here to have it here. And the topic of my lecture for today is the anatomy of the skull and the facial bones. And I will do my best to try to summarize the most important aspect that we routinely use in our practice in the OR. When we talk about, skull-base anatomy, and we have to consider that the pivot of the skull base is the great bat, as they told. So this is the sphenoid bone. The sphenoid bones articulate that constitutes the part of the neurocranium and also face the splanchnolocranium, that is namely the facial part of the cranium here. And the sphenoid bone articulates with the ethmoid bone, and they articulate inferiorly with the palatine bones. And here we have the most posterior half of the nasal cavity, that is one of the neighboring region of the skull base and the facial skeleton here. And also the nasal cavity is completed in the midline by the vomer, but we will come back to this critical concept here. And after that, we have the maxilla that constitute the most anterior part of the nasal cavity here. And we start to recognize the lateral part, medial part, roof, and the floor also. And now we have most of the facial skeleton. And this is the facial skeleton that we deal with the endoscopic approaches in the most of the cases. And this is the part of the skeleton with which we have to have, more confidence when we want to approach this kind of lesion by the nose. And then we complete all the cranium in the posterior part and the superior part with the frontal bone, and the rest of the cranium, especially the neurocranium. As I already told, this beautiful anatomy is critical to perform all kinds of skull-base approaches. And one of the most important concepts in terms of skull-base approaches is to have to clear in mind that we have some modules we should have some modules when we plan an approach and perform an approach, because each approach is carried out through specific bone corridors and through some bone corridors. And sometimes these bone corridors can be carried out through facial skeleton or neurocranium, and that's the entry door to the other structure that are namely intracranial. This is one of the articles that my group recently published in 2021, where we modularized the skull base from the intracranial side and the extracranial side in the anterior, middle, and posterior skull base. And we can start to identify near a midline structure corridor, paramedian and lateral. And as we see along this, lecture also, some of these approaches are carried out in the midline approaches, but paramedian and lateral approaches. And as we see here, most of today, endoscopic skull-base approaches are carried out in the midline corridor, starting from crista galli to the odontoid process of the C2. And here we don't have to forget the fact that we have not only an inner part of the skull base and the facial skeleton, but also we have an esocranial side of the skull base that is important as much as the intracranial side. And here, this is an overview of the neighboring region with which we have to face. The first one, critical, important one, is the orbit. And then we have the pterygopalatine fossa. It is very important because most of these approaches are carried out through the maxillary sinus, as I will show you here. And then we have the infratemporal fossa, mandibular fossa, parapharyngeal space. This one is very important for some kind of schwannomacy affecting the extracranial side of the lower cranial nerves, and then especially the nasal cavity. The nasal cavity today is one of the most important aspects that we have to face with in skull-base surgery, and this the nasal cavity opens with the piriform aperture here and communicates through the choana with rhinopharynx, and also inferiorly with the rhinopharynx, with the oropharynx here. And within the nasal cavity, we have the lateral, we have a lateral part, a medial part, a roof and floor. And the lateral wall of the nasal cavity is formed by the ethmoid bone, maxillary bone, and palatine bone. Is very, very important to have to keep in mind this concept. At the level of the midline, the medial wall of the nasal cavities is constituted by the nasal septum, and the most superior part of the nasal septum is formed by the perpendicular plate of the ethmoid bone that is completed inferiorly by the vomer, and the vomer has this attachment at the anterior part of the sphenoid body. And then we also have in live patient the cartilage that complete the septum here. And then we have also a floor that is constituted in the most posterior part by the palatine bone and the anterior part by the maxillary bone, especially what we call the palatine process of the maxillary bone. And the ethmoid labyrinth constitutes most of the roof of the nasal cavity here. This is another important concept that we have to keep in mind when we perform especially paramedian endoscopic approaches. Here, this is a right oblique view of the ethmoid bone, what they call the great shark. At the level of the ethmoid bone, we have two important structures. The first one is just lateral to the middle turbinate, and this is what we call the ethmoid bulla, that is most inferior part of the ethmoid labyrinth here. And then we have just anterior to it another important bony structure that belongs to ethmoid bone, that is the uncinate process. And in between the ethmoid bulla and the uncinate process, we have the so-called the semilunar hiatus, just inferior but also medial to the lamina papyracea, as we see here. That is, lamina papyracea is the most medial part of the orbital region, the orbit region. We have the so-called ethmoid infundibulum. This is a cross-foot. This is a carrefour that received the outflow from the air outflow from the anterior ethmoid cells, from the frontonasal duct, and also from the maxillary sinus. So when we move forward from the midline to the lateral part of the medial paramedial part of the skull base, we deal always with the so-called ethmoid infundibulum that is just inferior and medial to the lamina papyracea here, as we see. And this is a more closer view of the maxillary sinus here and the opening of the maxillary sinus at the level of the ethmoid infundibulum just below the ethmoid labyrinth. This is an overview of the most important bony structure that we have to keep in mind before to start to think to plan on to perform an endoscopic midline or paramedian skull base approach. This is an overview of the nasal cavity. Here we have vomer, we have the floor, the roof, and everything. And we have also the so-called concave crest. This is an important structure that belongs to the perpendicular plate of the maxilla with middle turbinates attached. And when we detach on lateralize or medialize the middle turbinate, we have to keep in mind that we detach the middle turbinate from this part that is the concave crest here. And also we have to note that these structures are covered by mucosa, and sometimes it can be just a little bit difficult to orientate when we see all this bony structure covered by mucosa. But we can see here the infundibulum, and we have our bony landmark for orientation, and everything is clear where we know very well the bony anatomy as just shown at the level of the nasal cavity here. And these are the main steps of initial approach to the nasal cavity, the vestibulum of the nasal cavity, and then we move forward. We identify the choana here, and we identify the inferior turbinate, the so-called inferior meatus, where the frontonasal duct, the inferior meatus where the nasolacrimal duct open, and then this is the right side approach, the nasal septum here, and this is the very, very important and very famous Haddad Vassagastegui nasoseptal flap that we routinely use for reconstruction of large and huge defect of the skull base after endoscopic approach. This is the right nostril approach. This is the nasal septum here, and this is the detachment, the compulsive superiostal detachment of the nasoseptal flap here. And here we see part of the vascularization of this nasoseptal flap that comes from the dorsal descending artery of the internal maxillary artery. But what we should keep in mind that the source, the core of the vascularization of the vascular supply of the nasoseptal flap is the so-called sphenopalatine artery that we see here with two branches. The sphenopalatine artery take off at the level of the pterygopalatine fossa from the internal maxillary artery here, and this is the core of vascular supply of the nasoseptal flap. We should never coagulate this artery if you want to correctly reconstruct the defect at the level of the clivus in most of the cases, or also the sellar part of the skull base when we want to use this kind of flap that is very useful. When we move to the anterior skull base, we have to always keep in mind that We have a special correlation between the intracranial side, the extracranial side. These are some of the important structures, the cribriform plate here and the fovea ethmoidalis. Cribriform plate and the fovea ethmoidalis are very important. Why? Because the cribriform plate represents the midline of the anterior skull base, and the fovea ethmoidalis is those part of the frontal bone that covers the anterior, that covers part in the articulation of the cribriform plate here. And these are the relationship that we have at the level of the anterior skull base with middle turbinate and everything. And when we move toward the anterior cranial fossa, we start to recognize the cribriform plate in the midline, the fovea ethmoidalis in the paramedian region. That is very important to be recognized when we want to approach the olfactory groove meningioma from below and from the nose. These are the variation of the transplanum transethmoid approach here, and we have the opportunity to tailor also this approach. This is transethmoid approach, transcribriform. That we have to keep in mind that the cribriform plate is no wider than the both rectus gyri. And when we want to expose and increase our exposure from midline to the paramedian region, we start to remove and to drill the fovea ethmoidalis here. And we have some variation, as we see in the bottom of this picture of this slide. We can move through transcribriform, transfovea ethmoidalis, and then fovea to fovea approach, where we maximize the exposure from lateral to lateral. And we go from lamina papyracea to another lamina papyracea and as a lateral limit without touching lamina papyracea here. But we can also increase the exposure of this kind of approaches from anterior to posterior, apart from lateral to lateral. And the last part, the most huge approach is the transcribriform, transfovea, transplanum approach, where we can expose part of the midline and paramedian corridor at the level of the anterior fossa of the skull base. This is what we expose when we drill cribriform and the fovea ethmoidalis, and this is the exposure of extradural and also intradural exposure here of the rectus gyrus, and we see also the olfactory bulb and the olfactory tract, the most initial part of the olfactory tract. Don't forget, for very young people, that this kind of approaches are very invasive here. We must reconstruct with some kinds of free flaps of vascularized pedicle flaps, and we also lost with this approach the olfaction. So these approaches are commonly and usually indicated in all people that have already lost olfaction, for example, in case of very huge anterior cranial fossa meningioma, midline olfactory groove of planum sphenoidale meningioma here. But we can also move eventually lateral from this kind of corridor to the orbital region, to the orbital apex especially, because when we drill the lamina papyracea, we expose the apex of the orbital region in the so-called transnasal, transfovea, transethmoidal, translamina papyracea approach, as we see here. This is another region where we move to, and this is the orbital region. The orbital region is another region that we should take into account when we talk about skull base. This is an overview of the 360 degrees approach to the orbital region. We can approach the orbital region by transcranial, transmaxillary, and transendoscopic approach, transnasal also. We can perform some approaches by the superior part, inferior part, lateral, medial part, and whatever you want. But what we should have in mind that, especially at the level of the floor, that is one of the most challenging parts to reach. We can approach this part of the orbital region with microscopic transmaxillary approach and endoscopic transmaxillary approach, using as entry door the hiatus, so the maxillary sinus here to enter the orbit. And this is one of the most beautiful papers that have been recently published by my brothers, Professor Eugel Dogruel, Professor Günger, and Professor Ture also here, where they show it beautifully. As you can use this kind of corridor, that is transmaxillary corridor, to beautifully approach the inferior aspect of the orbit here to remove any kind of lesion that lies at the level of the inferior aspect of the orbit. When we move to the medial skull base, as I already told you, we should focus in mind that we have some structure that belongs to median corridor, and these structure are planum sphenoidale, jugum sphenoidale, chiasmatic sulcus, and tuberculum celle. Tuberculum celle is the posterior limb of the so-called chiasmatic sulcus. And then we have the sellar region that we usually approach from below. And then we have the dorsum sellae. But we also have a paramedian corridor, and those structure, bony structure that belongs to paramedian corridor up the optic canal here, the anterior clinoid, the optic struct here also, the lateral part of the sphenoid body with the so-called carotid sulcus here, the posterior clinoid, and also the foramen lacerum here of the internal carotid artery. And then we have also, obviously, the lateral part of the skull base. Don't forget never the fact that in 22% of cases we can also have a middle clinoid process, and we have to keep in mind what are the relationship between the intracranial side and the extracranial side of the middle clinoid process, because the existence of a middle clinoid process can be very challenging when we perform anterior clinoidectomy from transcranial route, obviously in most of the cases. And here, at the level of the middle clinoid, we can have a bony bridge between the tip of the anterior clinoid process and the posterior clinoid process. And this is what we call the carotidoclinoid ring. And this is this should be part of the planning of the transcranial approach for this kind of skull-based approaches. One of the most beautiful and used corridor today is the transsphenoidal corridor. Transsphenoidal corridor is a very huge concept. Why? Because transsphenoidal corridors represent altogether a huge chapter with which we can treat most of the midline skull-based lesion. The most classic one is the transsellar transsphenoidal. That is a corridor that we use every day to treat small or huge also pituitary adenomas, but also we can have a transplanum transtuberculum approach where we use a corridor that is anterior to the transsellar approach to approach some lesion involving the anterior and also middle intracranial compartment and supratentorial space. But we can also use a transsphenoidal transclival corridor where these kind of corridors involve, to be honest, only the superior third of the clivus here, and in most of the cases involved hemi or total transposition of the pituitary gland to treat some huge lesion that involve the upper part of the clivus and the upper part of the infratentorial space. In the planning of this kind of approaches, we always have to, study the rate of the pneumatization of the sinus. This is the sphenoid sinus when we plan a transsphenoidal approach. When we talk about sphenoid sinus, one of the first and most used classification in terms of pneumatization of the sphenoid sinus is the so-called Hammer-Radeberg classification, where we can divide, this is the most classical one, we can divide the concal, sellar, presellar, complete sellar, and so on. But this kind of classification is insufficient today for most of the endoscopic skull-based approaches because this is only a sagittal classification. So that's the reason why in 2010, the Rotons group performed this overview in terms of classification of the pneumatization of the sphenoid sinus. This is beautiful classification that involves not only the sagittal plane, but also the axon and especially the coronal plane. Why? Because it can be, if the rate of pneumatization of the sphenoid body is excessive, we sometimes can have some uncovered internal carotid artery can be easily injured during drilling or during exposure. Even the mucosa, sometimes it is uncovered by the bone at the level of the sphenoid sinus. And we have to anticipate these kinds of challenging before surgery when we plan this kind of approaches also in simple transsellar approaches for small pituitary adenomas here. These are the main steps that everybody knows about the exposure of the sphenoid sinus. This is the concha crest. This is, sorry, the rostrum here. We remove the most upper part and the posterior part of the septum and the rostrum, and we expose the posterior wall of the sphenoid body. At the level of the posterior wall of the sphenoid body, we always have to recognize before to do everything, before to drill, before to remove tumor, before to remove everything. We should remove the mucosa here, and we have to recognize some critical structure before to do everything. One of the most important is the center structure, is the bulge. the bulge of the sellar floor. Just above this, we have the tubercular recess, and inferiorly to it, we have the clavicle recess here. And also, we have two further bulges here. The first one is the, the bulge of the carotid prominence. And this carotid prominence corresponds to the clinoid segment of the anterior carotid artery. And above to it, we have a third bulge that is the optic prominence, that is the divergent bulging of the optic nerve coming from the optic canal and running into the optic canal here. At the level of this, at the level of the posterior wall, we must recognize also two recesses. The first one is the medial recess, the medial, what they call medial OR or medial OCR, so medial optical carotid recess here, and lateral optical carotid recess, lateral OCR here. Because we have some specific correspondence between this point, right, the extracranial side and the intracranial side. As I show you here, just above the tubercular recess, we have the attachment of the diaphragm, and just in front of it, we have the chiasmatic sulcus, and just in front of the chiasmatic sulcus, we have the starting point of the planum sphenoidale. So if we drill just above the tubercular recess, we will expose the chiasmatic sulcus here, and this is the route that they usually perform when they operate some tuberculum cell meningioma here by the nose. And we have to keep in mind this, especially bony landmarks that are critical. When we open the cella here, we have two different options for treating the intradural structure. We have a suprachiasmatic corridor here, and in the suprachiasmatic corridor, we go above the chiasm here. And through the lamina terminalis, we can approach the entire third ventricle. We recognize here, because we are seeing from anterior to posterior, we see the thalamus here, the massa intermedia, the pineal recess, suprapineal recess, and whatever you want. If we go at the level of the infrachiasmatic corridor, so it means that we work below the chiasm, we beautifully expose the most superior part of the posterior circulation. So this is the basilar artery quadrifurcation with the third cranial nerves here, and the posterior cerebral artery, and the SCA, and the convexity of the pons. And we are seeing from the nose here at the level of the transcellular, transsphenoidal, diaphragmatic corridor here, and we can treat some lesion that involves this kind, especially craniopharyngioma when they involve the retrocellular space. This is a corridor that we usually perform and use. If we come back to posterior wall of the our body of the sphenoid, we have two important points. The first point at the level of the medial OCR is the medial optical carotid point, and the second one is the caroticocellular point. If we have this, keep in mind, we have that the lateral OCR correspond by intracranial side to optic tract, correspond to the optic tract to the intracranial side. Tubercular recess correspond here to the chiasmatic sulcus. We see here the correspondence between the esocranial side and the intracranial side. And it's very, very important to realize that the medial optical carotid point corresponds to the attachment of the middle clinoid process. So if we drill here, we expose the attachment of the middle clinoid process, and the middle clinoid process is present in 21–22% of the cadaver of the people here, and especially of some studies reported also, especially in the cadavers here. And if we drill at the level of the caroticocellular point here, we expose the so-called carotid sulcus, and the carotid sulcus groove the lateral part of the sphenoid body. So this important relationship and these important landmarks are critical before to start to perform this kind of approaches. And don't forget that if we drill at the level of the lateral OCR, we drill at the level of the optic tract. So basically, this is the last part of the anterior clinoidectomy that we every day perform when we do, and we, perform our transcranial approach, for example, for exposure to the paraclinoid aneurysms. This is still the relationship that we have when we remove the bone and we expose everything here. And we have the relationship with the medial optical carotid point that, as we see, is very, very close point to the takeoff of the ophthalmic artery here. we see the lateral OCR that basically correspond to the optic tract that is one of the 3 points of the attachment of the anterior chyroid process, of the anterior clinoid process here. And then we have the carotid-ocellular point that is most medial part of the cavernous carotid when the cavernous carotid runs at the level of the lateral part of the sphenoid body. And once again, these are the clear relationship after removing the bone and leaving the dura here. When we talk about this kind of the approaches, transfacial approach, these are mainly not transfacial, but endoscopic endonasal approaches where we use basically the facial corridors to approach some intracranial lesion. We need to have a new classification. This is one of the most recent that was reported by the CASAM group. This is Labib and colleagues that recently reclassified the internal carotid artery, introducing not a new segment, but a different segment that is the paraclival carotid. Why? Because we have to know that when we drill at the level of the Vidian canal, just lateral to Vidian canal, we can injure this kind of carotid, as I will show you very soon. And then that's the reason why in my book, I recently introduced this Labib paper here at the level of, this is most recent classification of the internal carotid artery here. And it's very important to have this is an overview of the different and very important classification, the comparison of the different segment with the relationship of the different segment of the internal carotid artery. And when we perform this kind of approach, we basically, face with the so-called C5 and C6 segment that namely are the so-called paraclinoid and ophthalmic segment of the internal carotid artery, and it is very important to keep in mind this kind of relationship. This is the carotid sulcus, and these are some specimens where I show you here at the level the posterior genu here of the internal carotid artery at the level of the foramen lacerum here, and the posterior genu at the level of the lateral part of the sphenoid body here. And also another important structure is the Vidian canal. The Vidian canal here is very important because it is the most important landmark to find the petrous carotid here. This is the most lateral and posterior genu of the carotid. If we follow the Vidian canal, if we follow the Vidian nerve, pterygopalatine nerve running at the level of the Vidian canal, we immediately find the posterior genu of the petrous carotid here. So this is one of the most critical and important landmark in endoscopic skull-base surgery. And this is once again an overview of the optic tract at the level of the same region. And also this is an overview, but I don't want to take too much time. This is just to show you that when we move just lateral to at the level of the cavernous sinus, we can approach the anterior wall of the cavernous sinus by endoscopic approaches. We can approach, obviously, the medial wall, but with so-called the ETMA approach, so ethmoid, the transethmoid maxillary sinus approach, we can also expose the lateral wall of the cavernous sinus, as I will show here, but the angulation is totally different. Here is the 25 degrees angulation, and we work here through the cavernous sinus, but we have to keep in mind this relationship because here we work basically at the level of the pterygopalatine fossa. When we identify the foramen rotundum that is just superior, as we see in this picture, and lateral to the Vidian canal and Vidian nerve, we have to have in mind that the foramen rotundum has some relationship with the projection of the foramen rotundum is critical to avoid injury to the internal carotid artery. Why? Because if we drill further lateral to the foramen rotundum, we can injure deeply the petrous part of the carotid artery. But if we drill medial to foramen rotundum, just superior, we risk to injure the lacerum part and the intracavernous and paracellular part of the carotid artery on paraclival carotid, as just show it here. And this relationship, when we perform endoscopic skull-base approaches, are critical to avoid complications, especially in terms of internal carotid artery injuries. And this is the exposure of the medial wall of the cavernous sinus with different steps. And we have here the exposure of the V1. So first trigeminal, second trigeminal division, meningohypophyseal trunk, where we have the inferior hypophyseal arteries here and the branch that goes to vascularize most of the cases, some meningiomas of the posterior clinoid, of the superior third of the clivus, and so on. And then we have some relationship between the intracranial side and the extracranial side at the level of the sphenoid sinus. So the anatomy is the same, but the view is different if we take a look to the cavernous sinus from intracranial side or from endonasal side. And here, this is what we know very well. So clinoid triangle, carotid oculomotor, supratrochlear, infratrochlear, and then also the skull-base triangle, the middle fossa triangle, anteromedial, anterolateral, Glasscock, posterolateral, and then the Kawase posteromedial triangle. And this is the relationship that we have between the exposure of the cavernous sinus from the endonasal endoscopic perspective and transcranial endoscopic perspective. And we have to know very well this kind of relationship, because when we are working at the level of the cavernous sinus from the nose, we have to know where we are in relationship to the sixth cranial nerve, first trigeminal division, second trigeminal division, internal carotid artery, and whatever you want. I just told you that we can expose it just for completeness purpose. We can expose the lateral wall, the anterior wall of the cavernous sinus, and the lateral wall of the cavernous sinus also through the maxillary approach. And this is the ETMA approach. The ETMA approach has some possible targets. Among these, we have the most important ones are the orbit, pterygopalatine fossa, infratemporal fossa, petrous apex, Meckel's cave, and also the cavernous sinus, especially the anterior wall and the lateral wall of the cavernous sinus. And I want to stress another important concept that here, when we perform an ETMA approach, so endoscopic transmaxillary approach to the cavernous sinus, the inferior aspect of the orbit, as I just showed, Professor Ture group recently also described an approach like the endoscopic one, but probably better from different point of view that can be performed with microscope, with transmaxillary. But regardless by which approach and which technique you use, one of the most important landmark is the infraorbital nerve. Infraorbital nerve is the roadmap that leads to you to expose the pterygopalatine fossa and also the foramen rotundum, the cavernous sinus, and especially the paraclavial carotid. That is very important, because if you follow this kind of nerve, we work just lateral to the paraclavial carotid, and we can avoid any injury of the of the paraclavial carotid. When we move inferiorly at the level of the posterior skull base, we have other important structure here. This is not an endonasal view. This is a transoral view from below here. And here, just to show you that you have the second and first vertebra, and thus we have the basion, the foramen magnum, the lower clivus. And one of the most important landmark is the so-called pharyngeal tubercle. Pharyngeal tubercle is a stout, bony prominence where the longus colli muscle attached here at the level of the cranium. And above this, we have the view in terms of the lateral exposure is narrowed. By which structure? By the medial pterygoid plate of the pterygoid process of the sphenoid bone. So it means that when we perform the posterior skull base endoscopic, usually endoscopic endonasal approach here, we usually expose the inferior part of the clivus here. But when we want to expose more lateral, we have to drill the medial pterygoid. So we have to perform what we usually call the transpterygoid approach to expose this area. But now I will show you better here. And then don't forget the occipital condyle here and the so-called supracondylar groove. That is another important landmark when we when we perform the so-called far medial approach. Far medial approach is the, is the transnasal endoscopic correspondence of the far lateral approach, but now I will show you. And once again, we have that anatomy is the same, but the view is different when we take a look to this structure by the intracranial side and the extracranial side. And at the bottom of these slides, you can see all the structure that we found when we perform transcranial approaches, especially condyle orientation, condyle morphodimensional anatomy, and whatever you want, and the angulation and the hypoglossal canal that is oriented in backward, in forward, orientation, and is oblique from posterior to anterior and from medial to lateral here. But we have the same structure that can be exposed with transnasal nasal transclavial approaches here, where we can reach even the most inferior aspect at the odontoid process that I will show you. The concept of the when we think about the posterior fossa, we are used to think about three neurovascular concepts according to a concept that has been introduced for the first time by Professor Roton. These complexes are the upper, middle, and lower neurovascular complex. Upper neurovascular complex is made by fifth cranial nerve and, you know, superior cerebellar artery here. Middle neurovascular complex, we have here HICA and acousticofacial bundle, also the sixth nerve. And then we have the pica with lower cranial nerves that constitute the lower neurovascular complex. We know very well that we can tailor the retrosigmoid approach, and we can tailor the retrosigmoid approach just to expose the superior, middle, and inferior neurovascular complex. But we can do the same when we approach this lesion by the nose in so-called transclavial approach. But what we should have in mind is the fact that we have to recognize some landmarks, and this bony landmark marks the limit between the lower, middle, and upper clivus. On the extracranial side, these landmarks are the pharyngeal tubercle that I just showed you, that is the Stoughty bone process, that is the attachment point of the longus colli muscles here, and especially the Vidian canal of pterygopalatine canal. If we trace an imaginary line at the level of the Vidian canal, we can, you know, identify the three aspects, and we have to stress also the fact that the upper clivus is sphenoidal. So when we want to expose a superior transclavial approach, this approach is a transsphenoidal transclavial approach because we enter the sphenoid sinus. Conversely, in most of the cases, when we work just below an imaginary line trace at the level of the Vidian canal, we work at the level of the middle clivus or lower clivus. So this is just transclavial approach, and this extra sphenoidal approaches here. And this is an overview on the sagittal view of the upper, middle, and lower transclavial approaches. And these are the main steps of the transclavial exposure of the posterior fossa here. And once again, the progressive exposure of the upper, middle, and lower neurovascular complex. At the inferior line here, we see what we call the transposition of the pituitary gland, just to expose the upper part of the clivus here and the upper third of the clivus. And we expose here the quadrifurcation. And this is, again, with the, we take a look with the angle, 30 degree or 45 degrees angled endoscope. We can see here with the posterior interpeduncular fossa here, with the posterior perforated substance and the thalamo-perforating arteries here coming from P1 and whatever you want. And then this is once again the exposure of the middle complex here. And then I don't want to take too much time. This is just to show you what we can do when we approach this kind of lesion by the nose in transclavial, transnasal. But we have to keep in mind very clearly what are the bony landmarks to expose this kind of structure, and perfect knowledge of the bony anatomy of the skull base, especially of the neurocranium and the splanchnocranium, is critical to tailoring the exposure and the progressive exposure of all this structure. And this is a case of total clevectomy. So we drill everything here and we expose the dorsum sellae to the basin of the clivus here. But this is just to show what we can do now today with midline endoscopic transnasal approaches. And this is a correlation that we have between retrosig and transclavial approaches in terms of the progressive exposure of the upper, middle, and lower neurovascular complex here. And these are the main steps of the far medial approach. As I told you here, one of the most important landmarks is the supracondylar groove. Why? This supracondylar groove is a depression that we can find at the level of the paramedian exposure of the transnasal transclavial area here. And just above this area, we have the jugular tubercle. So we can perform jugular tuberculectomy when we drill just above the supracondylar groove. And just inferior to it, we have the anterior tip of the occipital condyle. So it means that if I drill here, if I will start to destabilize my patient here. And this is just to show you how, having clear in mind this bony landmark, a bony relationship, we can easily perform endonasal extended transnasal exposure of the so-called jugular tubercle compartment and condylar compartment here, according to the lesion that we have to treat. And this is once again a comparison that we can do between what we know very well, that is a far lateral approach, but we can do the same thing in a tailored way, exposing the jugular tubercle area and the anterior tip of the condylar area here, also in far medial approach. And this is a paper that I published in 2019, where in choosing the most suitable surgical corridor between far medial and far lateral approach, my group identified and described here some critical aspects. The first one is a parameter that is the sagittal intercondylar angle. That is the wider the sagittal intercondylar angle, the greater the indication for a posteromedial approach, and the wider and the lesser this angle, the better is to approach the anterior foramen magnum meningioma from transclival route, transclinal, inferior part of the clive in the most of the cases. But it is just to show you that according to the perfect knowledge of the bony structure and bony anatomy, we have also the opportunity to draw some clear indication in between the far medial and far lateral approach for this kind of lesion. This is one of my last slides. This is just to show on cadavers what we expose. It is very easily here to identify what I just showed to you. C1, C2, basion, pharyngeal tubercle, supracondylar groove, jugular tubercle area here, condylar part here, anterior tip of the condylar, just lateral jugular foramen, and condylar canal here also below and inferiorly, and whatever you want. And this is my last slide, my last short video, just to expose you what we can do also when we talk about the endonasal odontoidectomy. This is a full endoscopic exposure of the odontoid process here and the anterior tip of the condylar. Everything has been cleaned here. We see the basion and the relationship between the vertebral artery and the intracranial side. And this is the most anterior part of the foramen magnum here, the vertebral artery and the exposure of the sixth nerve and everything. Thank you so much. I don't want to take too much time. Sorry about. I just want to share with you some humble point of view on how to summarize and to keep in mind some concept in terms of bony anatomy to safely and effectively perform this kind of approaches when we deal with the neurocranium and the facial skeleton also. Thank you. Can you hear me?
Thank you very much, Doctor. Dr. Majid. Dr. Majid, your microphone is closed.
I don't hear Dr. Majid. Probably he's talking, but is muted.
Dr. Majid, unmute your microphone.
Trying to unmute, but it's not. Now it's unmuted. Great thanks for Dr. Sabino for this very nice and very sophisticated lecture. I'm glad to hear such a lecture, and we welcome him to the program of the anatomy of the neurosurgical anatomy, where we will open the field for discussion if there is anyone who have a question about this lecture.
I'm totally available.
I will see in chat if there is any questions. Okay, someone is asking about the best source for studying scalpage.
My lectures.
It's a
Of course,
very nice lecture, yes.
Sorry about. There is no, to be honest, there is not a unique source. So what I show it is very hard work about collection of articles and chapters and experience by colleagues and whatever you want. So, but I do believe that for sure, for very young people, Roton is probably a Bible and a starting point for an overview in terms especially of osteology. But consider that Roton is very good for the beginners, but Roton sometimes has this defect, some small, critical, very tiny bone details that now are becoming very important as much as we refine, especially in terms of our endoscopic technique, are critical, you know, very small flat muscles. So probably we have to come back to test you or very, you know, detailed and super detailed anatomy book to discover some of these structure that can be used as an important landmark to revitalize the concept of anatomy and especially anatomy applied to neurosurgery. So we don't have a unique source, but we have to collect as much as we can.
Thank you very much, Doctor, for this nice presentation and very nice photos you show us. The level of the presentation is advanced and it's very nice for us neurosurgeons. But some of the medical students here or some of the undergraduates see this is difficult for them because it's very advanced for them. But it's very nice presentation and very nice dissections.
Sorry about, I perfectly understand that probably they're just a little bit advanced, but we can repeat it on the next week if you want.
you know, Dr. Sabino, the problem is that we have a shortage in the use of the
joking. So I know that I had, you know, you gave me a great responsibilities because it's an opening lecture about overview of the skull base, you know, and for a basic neuroanatomy course, but you know, we can stay here for 20 years talking about the anatomy of the skull base. That is a critical concept. Yes. So I tried to do my best to summarize as much as I could, as I can, all this concept. Sorry about it. We can repeat.
It's very nice presentation.
We can repeat for Christmas gift for younger people if you want.
Thank you very much, Doctor. It's very nice presentation and we learn a lot and it has a lot of details, but very nice details for all neurosurgeons. So thank you very much for your presentation.
Thank you.
I have here
again we hope to see you again for another lecture in our program, you know.
I just
asking about book.
Asking about book. I did it. Someone is asking me what about the book. I did it because, you know, I'm getting older, so it's difficult for me to read. What about the book? What, my book. No, to be honest, my book is about, you know, my book is about neurovascular surgery, but in the first 2 or 3 chapters, you can find all this kind of information because, you know, they are general and initial chapter about the anterior circulation, posterior circulation, and I love so much to, you know, stress some details. Apart from my book, where I try to do my best to collect all the critical and most important information in terms of that are important for neurovascular surgery, you can find lots of this kind of information also in internet because related to the approach, pterygium approach, COZ, all of this information have been collected in my articles also about far lateral approach and COZ and whatever you want. Okay, so take a look to my chapter, and also there are part of this article are mine, and also my advice for all of you is to read carefully also the chapter of my brother Professor Abuzer Gungor, that he was a fellow in the Roton's lab, so he's the king of anatomy, and he wrote lots of papers about anatomy, not only brain anatomy, but also some papers about beautiful papers about skull base anatomy. And this is our group, and we are dedicated, you know, we are dedicated 24 hours, 24/7 to the study of anatomy in the lab, as lots of people follow us every day. So my advice is to review our articles, and you can find everything there. Thank you.
Thank you, Professor. We have a question here in the chat. asking about the risk of inflammation in transoral approach for odontectomy. Yes.
Risk of inflammation. I didn't hear.
Yes, risk of inflammation or sepsis.
Or sepsis.
By using transoral odontectomy.
It's not negligible. That's the reason why the transoral approach, transoral odontoidectomy, that was the classic technique introduced by Professor Crockart in early 80s, have been, to the best of my knowledge, almost totally abandoned. Probably some surgeons perform this kind of approach for correction of severe deformity or deformity of craniovertebral junction. I know that Professor Benezes from India, and he was an Indian surgeon but works in the US, still performs sometimes in very complex cases, to the best of my knowledge, transoral approaches, transoral odontoidectomy. That is very, very rare. It has been today almost totally abandoned in favor of endoscopic endonasal approaches, even when we deal with complex pathology like ossodontoideum or cranial settling of the odontoid process of C2 associated with basilar invagination. So we need to decompress from the anterior this patient, and we usually perform this kind of approaches by the nose, and the risk of infection and the discomfort for the patient is 10 times lesser with endoscopic approaches than with transcranial approaches. But one thing that I want to stress, we have one of the most important landmark in the planning to recognize our most caudal exposure. That is what I showed you in my presentation. They call the nasopalatine line. The so-called nasopalatine line will be described by the group of one of my best friend, Professor Almeida, to the best of my knowledge, if I'm not wrong, because it was a few years ago. And they described this beautiful landmark because this nasopalatine line is an easily line that you can trace by the hard palate oriented in an oblique way toward the odontoid process. And if you're exposed, this is just to anticipate the most caudal part of your exposure. Okay, so the most oblique is the nasopalatine line. The more down you can go to remove everything, even, for example, some, C2 and C1 chordomas and whatever you want. So to reply to the first question, transoral approaches today are very, very, very small and few indication, and 99% of the approaches are performed by the nose.
Thank you very much, Doctor. I think I don't see any more questions in the chat. Dr. Majid, do you have any comment?
Actually, we would like again to thank Dr. Sabino about this very nice and very sophisticated lecture, and we hope to see him again in the next program, in our educational program, inshallah.
Okay, thank you very much. I want to finish this lecture with a comment, and apart from say thank you once again to Dr. Hamed, to Dr. Majed, to all my friends, all the new friends that are connected online. My heart is happy today. Why? Because I'm seeing so many people that are here because they are interested in anatomy and neurosurgical anatomy. So it's a critical point of surgery because, as Professor Roton said, surgery is anatomy and blood. So I'm very happy about this, and my humble advice for all the young surgeons that are connected here and all the young surgeons that will see this video on all our channel is don't stop to study anatomy every day and repeat the anatomy, because anatomy is the core, is the backbone of neurosurgical technique. Okay, thank you once again. I muted myself.
Thank you.
Thank you very much, Doctor. Dr. Majid, you can conclude our session.
Thank you very much, Dr. Ahmed, for this organization, and we like to see you again in the next lecture, inshallah. Thank you very much. If you have any comments.
Thank you very much, and thank you all for attending our first lecture of the comprehensive neuroanatomy course. And thank you for all speakers and all attendants and all our cooperative societies Before we leaving, I see here one question in the chat. Maybe you can. Is asking, skull-base anatomy varies from person to person or rhesus to rhesus? Yes, I think it's.
Sorry, I didn't understand anything. What's the question? Because I'm trying to do my best to read the question, but I didn't understand anything. What was the question?
I don't know if it's a question or a comment, really. Yes, Dr. Mu'tasim Al-Asari, he's asking very informative load. Where is it?
Dr. Al-Azali raised his hand. If you
Maybe
want
he's asking
Dr. Mu'tasim,
he's
you
asking,
can
yes.
you can unmute and you can ask.
Yeah, we are here.
Dr. Mu'tasim.
Hello, sir. Thank you for this informative lecture. My question is regarding to the skull base anatomy. Some books said that the skull base is as fingerprint for every person. There is a variable anatomy and variance between rhesus to rhesus, like Japanese to other South Asia.
Yeah,
Does the skull base anatomy, especially sphenoid bone, does it variable from the anatomical landmarks and structure from person to person or not?
usually in the human being, neuroanatomy is the same in all human beings. What you can have some variation, bony variation, but the main bony structures are the same in all human and in all humans. But what usually in the Japan, I know, I got you. I know what you mean, because I operated lots of Japanese people, and I totally agree with you about the fact that you can have some, differences in terms of pneumatization of the sinuses, orientation of the greater and lesser sphenoid wing, and especially another variation is the size of the squamosal part of the occipital bone. For example, Anatolian people, Professor Yashagi, never forget, always say, Anatolian people has a flat squamosal part of the occipital bone. These kind of variation are important because they can have some implication in surgery, especially in planning, or also in the outcome, or they can make difference. But usually this kind of variation takes no more than 2 or 3% in most of the cases. And my advice to young people is to study this kind of variation, to focus more this kind of variation, to go deeply in this kind of variation, to describe as much as they can this kind of variation. So you have the commitment and the role to describe all these variations that are very, very important, because this is the future of neuroanatomy. Okay, we know the basics. We are talking about the basics. This is a basic neuroanatomy course, especially we talk about bones and whatever you want, but we have to go deeper. And the next step is to study in detail that kind of variation that are critical and beautiful when we deal with complex, especially complex skull-based approaches.
Thank you very much. So by this, I think we can conclude our first session. Dr. Majid, you can have the finishing words.
Again, I'd like to thank all the attendants who share us the beginning of the scientific program, and I'd like to thank Dr. Sabino and Dr. Imran for their nice presentation, and we hope to we help them to follow our lectures next week, inshallah. Thank you very much for all.
Thank you.
Thank you, everyone. Our next presentation will be next Friday. We'll have 2 presentations at the same time, starting at 7 p.m. Yemen time and 4 p.m. GMT time. First presentation will be about the anatomy of the newborn skull by Dr. Suhail Agani, and the second presentation will be about skull sutures and overview of craniosynostosis types by Dr. Sajad Allah. So until next week, thank you everyone, and see you all next week.
Thank you, Dr.
Thank you everyone. Thank you, Dr. Majid.
Leave.